right, I've got a cup of tea, so I'll be drinking that as we do the lecture. So this is stroke. Let's buzz through the learning outcomes. So this is quite a nice overview of stroke. We'll go through pathophysiology, we'll go through the clinical signs, how you do the medical model based on this, and the principles of treatment. So let's summarise with the circulation of the brain. We can have anterior or posterior brain circulation. Let me go back, because we can have anterior or posterior brain circulation. So here's our aorta, ascending thoracic, descending thoracic aorta, brachiocephalic, common carotid, left subclavian. We follow the brachiocephalic up, it gives off the common carotid, which bifurcates. Our internal carotid will then bifurcate ultimately into our anterior cerebral and our middle cerebral. Now our subclavian, our left subclavian, will give us the vertebral arteries, and we'll get one from here, which is usually the brachiocephalic or the right subclavian. So let's just say the subclavians, vertebral, they form the basilar at the pontomedullary junction, run on the pons, the base of the pons, or the basalis pons, and they give us the posterior cerebral artery. So anterior circulation is ACA, MCA, and posterior is PCA. Now then, where does that leave us? So the circle of Willis is just something you need to know. You need to be able to tell me all of these branches. We won't go into it now. Well, maybe we will go into it now. So internal carotid, as we said, splits into anterior cerebral and middle cerebral. But here, just at the bit where the middle cerebral is formed, the anterior choroidal slips off. And that supplies things like the posterior limb of the internal capsule and the bits of the amygdala and the hippocampus and things like that. And a bit of the optic tract as well. So it's quite an important artery that's often overlooked in the circle of Willis when you draw it. M1, the first part of the middle cerebral artery, gives off these penetrating branches called the lenticulostriate branch, or the MCAP, the penetrating branches of the middle cerebral. A1 and A2 here, and the anterior cerebrals are joined by the anterior communicating. We have posterior communicatings that connect the middle cerebral and the internal carotid to PCA. Just before the basilar artery, which is here, and which is formed of the vertebral arteries, just before it gives off PCA, it gives off superior cerebella. Now just after it's formed by the vertebrals, it gives off anterior inferior cerebella, and these vertebrals give off pica, posterior inferior cerebella, and the anterior spinal arteries. So this you need to be able to draw out like the back of your hand. A stroke. It's going to be an infarct or a hemorrhage, or block versus a bleed. If it's an infarct, it's anterior versus posterior circulation. You're more likely to get an anterior circulation. And if it's a hemorrhage, it's going to be into the brain or subarachnoid hemorrhages. Those are our strokes. So funnily enough, 1 in 20 strokes are subarachs, and 1 in 10 strokes are bleeds into the brain. So this hemorrhagic stroke is more common than we think sometimes. So there's the Oxford, or it's also called the Bamford, so the Oxford-Bamford classification of ischemic stroke, which is divided 4 ways. 3 of them are based on the anterior circulation, tax, pax, and lax. So remember, internal carotids give us our MCA, which goes laterally in the Sylvian fissure, which is here, and ACA running on the top. Posteriorly, vertebrals give us basilar, give us posterior cerebral. So the posterior circulation is occipital lobe, cerebellum, and brainstem. So you can have cerebellar and cranial nerve, brainstem, palsies, which you won't have anteriorly. So anteriorly, you've got sensory and motor tract, you've got frontal personalities, you've got temporal emotions and moods and things like that. So a TACS, total anterior circulation syndrome, requires all of the H's. So you need to have them all. You need to have hemiparesis, paresthesia, so weakness and altered sensation. You need to have a homonymous hemianopia. Easiest way to do that is to draw 2 visual fields. So here and here. Homo, same. Hemi, side. Anopia, or anopsia, as it used to be called, vision loss. So for each eye, you have the same visual field defect. So homonymous hemianopia. Contrast that with pituitary adenoma, classically causing your bitemporal hemianopia. So this is a heterogeneous or heteronymous hemianopia because it's different for both eyes. This is our homonymous hemianopia we're looking for. and then higher cerebral dysfunction, and that's the remit of the higher neocortical structures. So things like speech, swallowing, language, personality. PAX requires 2 of TAX. So if you know PAX, you know TAX. And actually, if you know PAX and TAX, you know LAX, because LAX are lacuna infarcts, so they're just the penetrating ACA and MCA branches. They're the deep structures. So they won't be a homonymous hemianopia, and they won't be higher cerebral dysfunction. A LAX is pure motor and sensory with no other TAX. Okay? So it cannot be anything other than a totally pure motor sensory. That's your lacuna. Your posterior circulation is the back of the brain here. The occipital, the cerebellum, and the brainstem. Posterior circulation syndrome. The mnemonic to remember it is back. Bilateral motor and sensory is the fibres come together from the left and right hemispheres in the brainstem. You get another homonymous hemianopia because you're knocking out the occipital lobe. You're getting cranial nerve palsies and, crucially, cerebellar signs. And that's your back, B-A-C-K. Bilateral motor sensory, anopia, cranial nerves, and cerebellars. So your cerebellar signs, Danish, which every good medical student should know. So dystiadochokinesia and dysmetria, ataxia, nystagmus, intention tremor. The S stands for slurred staccato speech, and H is hypotonia and the heel-shin test. And then your cranial nerve palsy, so any problems with your cranial nerve osci, basically. There is another way to classify stroke, and it's based on syndromes. So, the quick and dirty rule of thumb here, just memorise this, draw out the brain and practice, basically. It's all colour-coded. Pause the video, learn that by heart. To the right, we have the homunculus, and the medial section of the homunculus, so the medial portion with the longitudinal fissures of the brain, this is lower limb and trunk. So if you have a lower limb symptom stroke only with the upper limb spared and the face spared, the head spared, the head and neck, it's just lower limb and it's ACA. Because ACA is the remit of this. Everything else is MCA. So if the lower limbs are spared, it's MCA. If the lower limbs are the only thing involved, it's ACA. It's that simple. Here's what ACA looks like. So it comes off, gives off an ophthalmic branch, gives off a frontopolar branch, and then you have this pericallosal branch. Like this. And then there'll be a callosal marginal branch, not here. Interesting enough, ACA here goes to the motor leg region and the urinary bladder region. So incontinence from an ACA stroke, yeah? ACA involves the foot and legs, so it looks like an A, the lower limb. If that helps you, it helps you. If it doesn't, it doesn't. So in your own time, read this. It sort of summarises it up. Just remember that if your dominant hemispheres, which is dominance is defined by language, if your dominant hemispheres are affected, you're going to have Broca's-Wernicke's, so expressive versus receptive aphasia, or if the arcuate fasciculus, which connects Broca and Wernicke's, is involved, then you will have a communicating aphasia. If your non-dominant hemisphere is involved, the classic sign is hemispatial neglect. Okay, so right-handed person, 90 to 98% chance that you will be left hemisphere dominant. So if there's a right MCA infarct, then you're going to have hemispatial neglect contralaterally, so the left visual field. You're not shaving, you're bumping into things, you're not getting dressed on that side. MCAP is just going for that internal capsule, ACAP internal capsule, PCAP internal capsule, right? Pica stroke is don't pick a horse that can't eat, because horse voice, because 10th nerve, and can't eat, swallowing, right? To distinguish pica and aica, pica is don't pick a horse that can't eat, and A is the facial nerve is involved. So you have facial signs, upper or lower motor neuron lesion. So that's the difference. If it's aica, it's 7. If it's pica, it's lower down. It's 9 and 10 that you're thinking about. So, here is a liquefactive necrosis, which is a specific type of necrosis that occurs intracerebrally. 5 different stages to know. 2 stages are red. Okay? First stage, within the first day. you have a red formation as the eosinophils co-ascend. Eosin means orange, so the orange-loving eosinophil, orange-loving cells descend. By day 3, they're replaced with neutrophils, so we lose the red. By day 5, the specialist phagocytes of the central nervous system called microglia invade. So now we have microglia, and they will stay for the rest of time. The innate immunity of these granulocytes go away. The microglial cells undergo what's called reactive gliosis, where they trigger proangiogenic growth factors to come in because they're working overtime. They haven't got long. After 2 weeks, they scar over, which is the last stage. So they haven't got long, so vascular proliferation occurs. Loads of blood vessels are formed quickly. They're a little bit leaky because they're formed too quick. It's like if you build a house on the cheap. Formed too quick, there's a bit of leaky. So red phase, second red phase, because you're leaking a bit of blood. And then the things scar over. And pathologists will use this to see time of death, right? So massive bleed, patient drops dead. If there's no eosinophils, if they haven't even got to the eosinophil phase and it's just a clot, then we know they've died in less than 12 hours. If massive bleed on the brain, pathologist says it's just a glial scar, then it means that it's been present for greater than 2 weeks, so it's not likely to have killed the patient. Or if it's killed the patient, they've been in ICU on ventilators and things, so yeah. Obviously, you view the whole patient and not just one pathologist report. So let's use the medical model, which is a differential. So a patient presents with headache. So you do a differential. Is it primary headache, so migraine tension clusters? Is it trigeminal neuralgia? Or is it some other mimic of a headache? All those are the sorts of things that it can be. So a secondary headache, basically. Or then you do the history. So you do a focus history based on that patient. Then you will undertake the examination, do the investigations management, and follow up with the patient. So breadcrumb trail at the top. Let's start with differential. So CVA is the posh term for a stroke. It's a cerebrovascular accident. Cerebrovascular. So brain vasculature accident. So it's an acute thing that happens. So it can be a TAX, PAX, LAX, or POX, also a TIA, which means that symptoms entirely resolve in less than or equal to 24 hours. So if you have a TIA for longer than 24 hours, it's a TAX, PAX, LAX, or POX. It's a stroke, it's not a TIA. So strokes can present, but they're not necessarily strokes. So there was a patient on the wards today with a slow-growing tumour who'd been diagnosed with a stroke at presentation because they had left-sided hemiparesis on examination. So they had a PAX. That's what they were diagnosed with. Turns out, on brain scan, after the Rosier and the ED, the rule-out stroke in the emergency room is the assessment they do, which we'll come to later when we get to the investigation stage. The patient had a malignancy. So the way to remember stroke mimics is the mnemonic mimics. M, malignancy. I, infection. M, migraine aura. I, insulin, having a hypo. C, clot hematoma. And then S is a focal seizure. So, rule of thumb, nice little tidbit from neurology. Mimics are normally a slower onset. The patient will have a lower GCS and vaguer symptoms. A stroke is a stroke. It's a boom. It's a cerebrovascular accident. It's a sudden thing and then bam, the patient has attacks. It's not slowly coming on like a slow-growing tumour or an abscess. History and examine the patient. So we'll use the mnemonic BFAST. Whoops, I thought I had the laser pointer on. BFAST. So remember the FAST screen that Public Health England did a few years ago, face, arm, speech, time. If you add B to the start of it, you get all of the questions for a focus history of the stroke patient that you need to specifically ask. B is barfing and balance, so are they vomiting? E is eyes, visual field defect. Remember the homonymous hemianopia coming up again and again and again, except in lax. F is face, and A is arms and legs, so both limbs, motor and sensory loss. S is speech, we've thrown in swallowing as well. And then T is not time, it's thunderclap headache or other kind of headache. These are the questions you need to ask. And then your classic modifiable and non-modifiable risk factors. We can't change the fact that 65-year-old men stand a greater risk of a stroke than a 35-year-old man, but we can control the patient's blood pressure, which is a modifiable risk. So, investigation-wise, we have bedside, bloods, imaging, special. This is the 4-part process that you should always use. There are no specials for this patient, so don't worry about that. At the bedside, you can order an ECG and a glucose. You can order glucose because a hypo, a person with poorly controlled diabetes, particularly type 1, are at risk of presenting with stroke-like symptoms. You'll order an ECG because of the thrombogenic nature of atrial fibrillation. In terms of bloods, you're going to order full bloods, white cell and ESR, the acute phase protein. You're going to order a CT/MR head, and this has to be within 24 hours of symptomatic onset, or if it matches the emergency criteria, which includes coagulopathies. So whether that's iatrogenically caused via oral anticoagulants or antiplatelet therapy. If they're in the thrombolysis window, which means if onset of symptoms has occurred in less than or equal to 4.5 hours, this may be revised to 6 hours with new evidence, but currently it's 4.5 under most CCGs. If the patient has a deteriorating GCS or signs of hemorrhage, so for example, thunderclap headache is indicative of a subarachnoid hemorrhage. The worst headache in their life, it's sudden, it's specific, it's really sharp and painful. Then you need to be thinking, whoa, this patient could have a subarachnoid hemorrhage and SAH. They need an emergency CT scan. They can't wait 24 hours. It has to happen. Management. So, pre-hospitally, the patient will have a FAST scan. FAST, face, arm, speech, time. Face, smile. Check to see that you have smiling bilaterally. Arms, lift your hands above your heads for me. Check to see that that is happening fine. There's not one hand above the other. Speech, say something for me. So repeat this sentence, the quick brown fox. The quick brown fox, fantastic. If you don't think they're having a hemorrhagic stroke, if they don't have reduced level of consciousness, if they're completely alert, is what we're saying, so GCS 15, and if they don't have a headache, they don't have any of the hemorrhagic signs, any signs of shock or whatever, then aspirin 300 milligrams, you give pre-hospitally. The people on 999 will tell you to take that, and the paras will give it to you if you don't do it. Note the time that it's taken, obviously. ED confirmation of diagnosis, so this is Rosier. So I've just summarised FAST, and you can remember Rosier, but 2 key points to take home. If you remember BFAST, barfing and balance, eyes, face, arms and legs, speech and swallowing, and thunderclap headache. They're basically points. If the patient has a decreased level of consciousness or has had a seizure, this kind of is a negative to the fact that they're having an ischemic stroke. Okay? It's more likely to be a hemorrhagic stroke or a stroke mimic that you need to then consider. So, neuroimaging, as we said, 24 hours or emergency. Neuro will tell us if there is a hemorrhagic stroke, if you see a bleed, intracerebral, intraventricular, or subarachnoid. And if you do see a bleed, then you operate or don't operate, but we'll come to that. Ischemic stroke, so there's no bleed. Okay, when did symptoms begin? If it was less than or equal to 4.5 hours, we're giving alteplase. We're going to bust the clot with thrombolysis, which is a recombinant tissue plasminogen activator, TPA. Plasminogen comes and breaks up the clot. It breaks down those thrombin and cross-link chains. If it's greater than 4.5 hours, there's no evidence to suggest, in the current guidelines, that alteplase is useful. So we just continue aspirin therapy to prevent subsequent stroke, and they need to be in a level 1 stroke centre with nursing, physio, occupational therapy, and neurologists and neurosurgeons who are specialists in strokes. There should be fellows. There should be neurology stroke fellows or stroke consultants specifically doing stroke full time. Hemorrhage, if it's cerebellar or brainstem, we will evacuate the blood if neurosurgical consult agrees. But if it's cerebral, often we don't evacuate because evidence shows that actually outcomes are worse if we try to intraparenchymally operate. So we give beta blockers and calcium channel blockers. We just treat conservatively a cerebral bleed. And again, back to the level 1 stroke centre. I'm not going to read this slide to you because it's very common sense. This is the secondary management of stroke. So make sure you can deal with that. And these are my sources. So, yep, pretty straightforward. This is where I would normally ask for any questions. Oh, and then of course Dawn. The Block 3 lead. That's it, thank you.